My name is Monica, and today I will be doing a presentation about mental illness. According to the National Alliance on Mental Illness, it is a condition that affects a person's thinking, feeling, behavior, or mood, which deeply impact the day-to-day living and may also affect the ability to relate to others. Mental health conditions are far more common than many believe it to be, but are not talked as much because people avoid talking about it or are scared to talk about their mental illness. 1 in every 5 U.S. adults experience mental illness each year. 1 in every 6 youth aged between 6 and 17 years of age will have a mental health disorder each year. 50% of all lifetime mental illness begins by the age of 14 and 75% by the age of 24. Genetics, environment, and lifestyle influence whether someone develops a mental health condition or not. And today, I will be talking about anxiety. The reason why I chose anxiety is because I have experienced many episodes of anxiety, which included insomnia, muscle tension, where I clench my teeth and now I need a retainer, and also constant worry. So I want to just bring some awareness and allow further discussion about this condition. The patient is a 48-year-old female dentist with a 7 months history of anxiety symptoms, which included persistent feeling of restlessness, irritability, difficulty concentrating, sleep disturbance, fatigue, nausea, diarrhea, muscle cramps, and the sensation of having a lump in her throat. She was suffering from constant worry that her husband could become ill or might have an accident while driving to work. Her symptoms resulted in frequent absenteeism, which caused significant problems at work. The psychiatrist diagnosed her with generalized anxiety disorder. The patient started a low dose of venlafaxine, which was gradually increased, and she also received the weekly sessions of cognitive behavioral therapy. The outcome goal absence of symptoms within 7 weeks of the treatment. The second outcome is for the patient to be able to recognize signs of escalating anxiety and intervene before reaching panic level. Recognizing precipitating factors is the first step for the patient to learn how to interrupt the escalation of anxiety. The therapist will teach you signs and symptoms of escalating anxieties and ways to interrupt its progression, which include the relaxation techniques, such as deep breathing exercises and meditation, or physical exercises such as brisk walks and jogging. Relaxation techniques results in physiological responses opposite to that of the anxiety response. Physical activities discharge excess energy in a helpful manner. Third outcome. The patient verbalizes ways to intervene in escalating anxiety within a week, such as intervention that includes hyperventilation, where the patient can use their paper bag to take about 6 to 12 natural breaths to increase the level of carbon dioxide, which will avoid risk of lightheadedness, rapid heart rate, shortness of breath, numbness, tingling in the hands or feet, and syncope. Nursing intervention will include staying with the patient and offer reassurance to safety and security, never leaving the patient during a panic anxiety alone. Presence of a trusted individual provide a feeling of security and assurance of patient personal safety, maintaining a calm, non-threatening, matter-of-fact approach. Anxiety may be transferred from staff to patient and vice versa. General anxiety and patient safety. Factors that could protect patients against major psychiatric disorders presented in a study that explored psychosocial risks, which are the negative interaction, and protective factors such as family cohesion, social support, religious involvement, racial and ethnic identity. Negative interactions were associated with increased likelihood of general anxiety disorder and suicide ideation, whereas family cohesion seemed to be protective against general anxiety disorder. Longitudinal study demonstrated that the presence of any anxiety disorder in combination with a mood disorder was associated with a higher likelihood of suicide attempts when compared with the mood disorder alone. The study aims to demonstrate that a pre-existing anxiety disorder is an independent risk factor for subsequent onset of suicide ideation and attempts. The data clearly demonstrate that the comorbid anxiety disorder amplify the risk of suicide attempts in persons with mood disorders. Clinicians and policymakers need to be aware of these findings, plan treatments and intervention for anxiety disorders to reduce the risk of subsequent suicide behavior. It is important for nurses and providers to understand risk factors for suicide behavior and intervene prior to the individual making the first suicide attempt. In a cross-section analysis among all of the respondents with suicide ideation at baseline, 52.4% had at least one anxiety disorder. Of all respondents reporting suicide attempts at baseline, 64.1% had at least one anxiety disorder, proving that an anxiety disorder is significantly associated with suicide ideation, suicide attempts, and complete suicides. Now let's talk about regulatory factors. National treatment guidelines for generalized anxiety disorder treatments include antidepressant medications such as buspirone, benzodiazepines, cognitive behavioral psychotherapies, and relaxation therapy. Unstructured therapy techniques are also used. Treatments are often effective, but patients frequently do not receive them. The National Comorbidity Survey included patients between the age of 14 and 55 years of age, and only 31.8% of people with general anxiety disorder reported receiving outpatient mental health services when going to their general medical visits. Many general medical patients may not recognize that they have an emotional problem. Researchers have found lower rate of mental health treatment utilization among men, ethnic minorities, elderly, young adults, and individuals with lower socioeconomic status. The epidemiologic catchment area study found that access to care was better under Medicaid than those insured or those with private insurance. And the medical outcome study found that some aspects of treatments were worse in prepaid care. Primary care provider contact was most common with anxiety disorder, and specialist contact was most common when both anxiety and depressive disorder were present. Only 17.6% of all participants received appropriate counseling. In all, 30.4% received at least one appropriate treatment for the disorder. The substantial problem with access to mental health treatment occurred even among persons receiving health care. In fact, 76% of individuals with poor quality care had seen healthcare professionals during 1 year period. Most had been seen by a primary care setting, making these locations most indicated for identifying individuals who could benefit from the treatment. Healthcare organizations. Many governments are concerned with growing health expenditure and the need to allocate resources efficiently. There is a wide variety of strategies used by the health system to control growth of pharmaceutical costs and drug approval procedures to decision about coverage, reimbursement, and distribution. In the United States, complex pharmacy benefit management programs are common, with tiered cost sharing depending on the type of medication involved. Doctor's budget, also known as capital payments, may include pharmaceutical costs and some proportion of savings that can be returned to the practice. Policymakers should remove barriers to treatment like co-payments for specified cost-effective service and reducing distance barrier and wait time to receive treatments. Reimburse mental illness professionals at the same time, effort, and expertise levels as those providing other medical services. Patients with general anxiety disorder have been found to be frequent utilizers of primary care resources rather than mental health specialists. Anxiety disorder also has a major impact on society because it is associated with significant economic burden due to their decreased work productivity and increased healthcare utilization. Studies showed 34% of patients with pure anxiety disorder reported difficulty executing their workload. It has been reported that specialists seen most often by anxiety disorder patients are gastroenterologists. Only 10% of patients with anxiety disorder have been seen by psychiatric specialists. 50% of patients with general anxiety disorder had seen 1 to 2 medical specialists because patients with anxiety disorder visit a number of physicians before they are definitely diagnosed and treated. A study conducted in the National Comorbidity showed that only 48% of all pure general anxiety disorder subjects had received healthcare intervention at some point in their life. The economic cost of anxiety disorder has been examined, and studies indicate that the annual cost of anxiety disorder was between $42 to $47 billion in the U.S. The three largest components of the total cost comprised of 54% in non-psychiatric medical treatment, 31% in psychiatric treatment, and 10% in indirect workplace costs. Prescription pharmaceutical costs were a minor factor, accounting for less than 2% of the total costs of anxiety disorder. Of the $4 billion in indirect workplace costs, 88% of the cost per individual was attributed to the lost productivity while at work, as opposed to actually absence from work. The prevalence of depression and anxiety is unequally distributed between population subgroups, and that depression and anxiety are associated with unfavorable consequences in social and economic living conditions, health, and survival. Degree exposed to the risk factors such as poor physical health, precarious employment conditions are in general higher in low socioeconomic status group. Furthermore, being exposed to several risk factors at the same time increase the vulnerability to depression and anxiety. The economic consequences of this disorder may also be more severe in lower socioeconomic status groups, as social position may impact the access to treatment and rehabilitation, as well as labor market opportunity for individuals with reduced work capacity. For potential policy intervention addressing health inequality can be utilized by nurses. Health inequality could be intervened by acting on social stratification, which include granting access to education for young people from all social backgrounds and providing support to those who need it. By reducing exposure and vulnerability to factors such as precarious work or financial difficulties that are increasing the risk of mental health among those in this disadvantaged group. It could also be done by reducing the differential social and economic consequences of mental health, like providing rehabilitation, labor market opportunity for those with reduced workability. From a policy perspective, it is important to note that the economic consequences of mental health differ between population groups, such as social and mental health care policies that can be developed to counteract inequalities in society. This can be done not only by addressing inequality in risk factors for these disorders, but also addressing the inequality and the consequence of these disorders. Thank you so much for watching my presentation, and I hope you enjoyed it.